the first case we are going to examine will be, pay attention, this one, lobular pneumonia. So, open the slide, please. And we'll try to identify this structure. This structure. What does it look like? What histologic structure is this within the lung parenchyma? It could be, it has a central lumen, some sort of cavity, a central lumen, and you see well orientated, well recognized epithelium, lining epithelium. And if you have a higher magnification, what type of epithelium is this? Look, the nuclei, yes, that's right, the nuclei appear in different levels, so it's a pseudostratified respiratory type columnar epithelium. It lines the upper respiratory tract, the trachea, and central bronchi, and generally large bronchi, because in bronchioles it is not so well recognized. It is somehow flattened, and this has the continuity to the alveoli, where you have the pneumonocytes lining the alveoli. So this is a bronchus, and you see here in the wall of the bronchus, this tissue, you see, this tissue here, which when it contracts, we have bronchoconstriction, as it happens in asthma, all right? However, the bronchus shown here has no pathology because the lesion affects only the alveoli, and that's what we are going to see. So it is not some sort of bronchopneumonia, that means inflammatory infiltrate of the bronchus wall and the adjacent alveoli. No, the bronchus is not affected by inflammation. So let's see the part of the lung parenchyma that is affected by inflammation, and let's see where the exudate accumulates. So, look here. Do you recognize these septa? See how congested they are. Congested. That means there is much blood has come there. Why? In response to the stressful stimulus of the inflammatory agent, the agent that caused inflammation. In this case, most probably, it is a bacterium, Streptococcus, in most of cases. So, this part that you see here, the capillaries within the septa, the intraalveolar septa, they are congested. This is the first sign of inflammation, because a lot of blood goes to the tissue where damage was done. Next, what characterizes the next step of inflammation? We have the formation of exudate. And where does exudate enter? It enters the alveoli. So instead of being filled with air, they are filled with the inflammatory exudate, and this causes problems. That means inflammation started to face the problem, but it causes problems itself. And since the alveoli of a whole lobe communicate with each other, the inflammatory infiltrate may fill a whole lobe, so this is called lobular pneumonia. When we talk of pneumonia with no other adjective, we mean this type of pneumonia. That means alveolar pneumonia. Exudate within the air spaces of the alveoli. Now, let's try and identify the cellular elements of the inflammatory infiltrate. What are these cells most probably? Have a look. These ones. Have a look at the configuration of their nuclei and compare this cell here and this one to this one. Have a look. This cell and these cells here. What is the difference? Have a look at this one. It's very typical. And the neighboring cell. How do they differ? What do they differ? Morphologically. Yes, please. One has a multilobulated nucleus and the other a round nucleus. So we have neutrophils, polymorph for nuclear, and we have the mononuclear, known as macrophage. So what did neutrophils go there to do? They went there to kill the microorganism, the streptococcus. Then the macrophage came to tidy all the area of the remnants of the inflammatory exudate. So as far as the cellular elements are concerned, we have neutrophils and macrophage. A neutrophil and a macrophage. So now that I'm showing you the slides, there is no need that I'll show you the slides in the preparatory lesson for the midterm exam. I have it video taped so you can look at it. And when we'll have the preparatory lesson, we'll have the slides of circulatory, gastrointestinal, and liver. Not the respiratory, because that's what we do it now. Okay, yes, please.
Can you just show the macrophage?
The macrophage?
Is it that?
Yes, come and you ask me. But take care because it's the video. The video is on. No, not you, not you. So who wants to ask me and identify the cells of the inflammatory infiltrates? Now, you'll be the professor. Okay. Don't laugh. You must be strict. Okay. Don't laugh. That's the way. That's the way. So, show me, please. You'll show me all the cells, and I'll try to identify them based on the shape of the nuclei. All right. Show me one. The easy one first. The easy one first. Ah, that's a macrophage. Don't leave. That one. A macrophage. This is. You see, the nucleus is round, mononuclear cell. And it's an excellent. This is a typical neutrophil, this one. You see, the lobulation, this is a macrophage. The macrophage, the neutrophil.
Sir, can I ask something?
Of course you can.
For me, if I would see this, I would say that this is mitotic activity.
No, because in mitotic activity you have a line. You have a line. The nucleus becomes a line with some irregularity because it's the attract that's going to divide.
Is the last stages of the mitosis?
No, in the last stage you see two separate cells. Okay? Yes. But there is another element of the inflammatory exudate that it's not cellular. That means there is some sort of amorphous, non-cellular material. Can you identify that? What's your name?
Theophanis.
Theophanis, can you identify? These are cells, the cellular element of the inflammatory infiltrate. What else can you see, apart from red blood cells? What else can you see? Amorphous. No, don't move. There. Are there some sort of strands of a material? Show me with the mouse, please. Excellent. What is this amorphous material? Excellent. This is fibrin. That means it's fibrinogen when it is in the blood. When we have the endothelial cells activation, they form gaps. So fibrogen passes through the lumen to the tissues, and it's polymerized, and we see it as fibrin. And if this exudate is organized, it forms strictures. As we said, in cases that we have the peritoneal cavity, the pericardium cavity, the pleural cavity, in these areas where we have this mesothelial lining of the structures forming the cavity, the inflammatory exudate is full, is rich in fibrin. So if it persists and comes to chronicity, it forms strictures. And this binds the two layers of the pleura, of the peritoneum, and may cause obstructive ileum. As far as the peritoneal cavity and the intestine is concerned. Yeah, please.
I wanted to ask, can this tell us also the days, like, do we follow that, okay, for example, since there is fibrin, it's been 1 week since the...
The chronicity, no. If you see neutrophils, that means acute inflammation. if you see mononuclear cell infiltrate apart from macrophage, that means lymphocytes, this is chronicity. Chronicity is defined by a mainly mononuclear inflammatory infiltrate consisted not so much of macrophage, because macrophages get out right after the neutrophils, but of immune cells, lymphocytes, small, mature lymphocytes, or plasmacytes. The site of chronic inflammation is plasmacyte. And what, yes, please.
Because we know also that the lung has elastic fibers.
Yes.
Couldn't we?
They could be affected
no.
by the proteases of the enzymes of the inflammatory cells, and this might predispose to a loss of elasticity.
Later.
And this could be related either to atelectasia, where they collapse, the alveoli collapse, or on the contrary, if the septa break, they cause emphysema.
My question was, how can we separate in the histology? How can we?
To see what in histology?
The elastic. I mean,
You have a stain for elastic fibers of the connective tissue, not for elastin. If you want to see elastic fibers, you have a specific silver stain. But these are fibers of the connective tissue. The wall of vessels have elastic fibers. This is not elastin. Okay?
it will be normal if I had that silver staining. It will be normal now.
Yes, yes. This is not an area of fibrosis. Pay attention, and we'll see it next. So, now, Theophanis, we have the inflammatory exudate. Okay. Now, I want to go to another area. Since we were here, have a look at these big cells. You see? And they have some sort of inclusion here in the nucleus. Yes, it's something like, this is CMV, cytomegalovirus. That means that this patient is immunocompressed. That's why the inflammation persists and causes the complications we are about to see now. What are the complications? One complication related to streptococcus is this area here that it's very difficult to see viable tissue because this is a necrotic area and this is nuclear dust. So how do we call the necrosis that is related to bacteria? How do we call it? From the pathology point of view and from the clinical point of view. The necrotic material caused by the toxins of bacteria. How is it called? It's a type of necrosis. It's not the casus that tuberculosis does, it's the liquefactive necrosis. But from a clinical point of view, excellent, this is called pus. So, when pus is formed in an area, what does it do? If it is within a solid organ, it tries to open a way so that it reaches a free cavity and be spread there. And in this case, it will find the pleural cavity. And we have the pleural embyema, because this is a pre-existing cavity that has become filled with pus. This is an embyema. What else can it do? If it is on a covering epithelium, it will destroy the epithelium, and this will be an ulcer due to inflammation. And in this case, it will form a cavity, some sort of cyst, that it will be filled with pus, and on its periphery, connective tissue will develop here. Look, this is connective tissue. Here we have a zone of viable inflammatory cells. Why do I call them viable, Theophanis? Because I can see full nuclei, the whole nuclei, not just dust that I saw in the pus. So these are viable neutrophils. You see that the majority is neutrophils. You see the lobulation of the nuclei. And this forms some sort of cyst that contains pus in the cavity. How is this complication formed? Called? Yes, this is an abscess. An abscess. So this is a complication of pneumonia that formed a collection of pus within a cyst-like structure, a cavity, which is surrounded by fibrous tissue. And if you give chemotherapy, if you give antibiotics to treat the streptococcus, they cannot reach the area where the microbes are because there is not enough blood supply in this area. As you can see here, this is the area where we see vessels. There are no vessels in the area of the pus where the dust. You see, this is the dust. These are not whole nuclei. These are remnants of nuclei. These are necrotic cells remnants, the nuclei of necrotic cells remnants. So the only way is surgery. When an abscess is formed, the only way to treat it is surgery. And another complication of chronicity is evident here, where you see that there are some alveoli being some sort of suffocated by fibrous tissue, which is not normal in the lung, this fibrous area, because this is related to the inflammation chronicity. That means that due to the persistence of the inflammatory exudate, macrophages secreted fibrogenic factors, mainly transforming growth factor beta, which had a chemotactic attraction of fibroblasts and collagen deposition. So we have a fibrotic area which involves the alveoli. That's why their shapes are abnormal. You see, they are some sort, here these ones are full of exudate, but you can see that the size is relatively retained. Here are the septa. Here is the airspace filled with exudate, of course. However, in the other area, they are deformed. You see? And this is a hypocellular tissue. That means it's not so much a desmoplastic response. This is fibrosis. So it is an area of fibrosis, in this case, due to the organization of the exudate. It was not possible for the inflammation to go to lysis. So we had organization of the inflammatory exudate and chronicity in the form of fibrosis. Of course, there are other cases where fibrosis is not related to the persistence of an inflammatory exudate, but it occurs on its own, on itself. And what are these cases of lung diseases? The idiopathic fibrosis, the restrictive lung diseases, the ones possibly related to pneumoconiosis, that means substances that come in the lung from professional exposure, if somebody is working in a coal, a mine, and they can cause fibrosis too. And another type of disease that may lead to fibrosis and sclerosis of the lung is when we have left heart failure, because this leads to congestion of the pulmonary circulation and possibly pulmonary edema, which needs treatment with diuretics so that it is relieved. But if it persists, this may also lead to fibrosis on the long term. If we have a permanent congestion of the pulmonary circulation. Yes, please?
Why not right heart failure confuses? Why not
Right heart failure causes congestion to the periphery because it cannot send blood to the pulmonary artery. So in right heart failure, we have hepatomegaly, ascites, symmetrical edemas in the limbs. Right heart failure. Left heart failure, we have congestion in the pulmonary circulation. mainly after a myocardial infarct, but also from mitral valve stenosis or insufficiency. All this can happen. And what can this cause? Let's have a look at the other slide. Yes, please.
Before we move on, can I ask something?
Yep.
The bacteria always cause the liquefactive necrosis.
Liquefactive necrosis. Pass. This is pass from a clinical point of view. Yep.
So there is no way they could cause coagulative necrosis.
Coagulative necrosis is always related to ischemia in all organs apart from the brain. Because in the brain it is liquefactive, even though it is ischemic. The only necrosis that is liquefactive, despite being ischemic, is in the brain. And this causes cavitation. It causes a cavity, not fibrosis, as in other parts. Okay, now, our next slide is this one. You see this one? You open it from your electronic devices. And the same is this one. Let's try this one because it's a bigger section. So where is the fibrosis here? I'm not so sure that I can see fibrosis. However, I can see a pigment. You see the pigment here? In which cells of the lung might this pigment accumulate? Yes, please. In macrophages, yes, because we have the alveolar macrophage, resident macrophage. So when you have, in this case, the pigment it appears brown, as you see, but if you have pearl stain, it gives it some sort of green to light blue color, and this is hemosiderin. And perhaps these macrophages can be excreted in the sputum in patients with less heart failure. So these are known as siderophages. That means that it is from hemoglobulin that has come out of the vessels with the red blood cells, and it was phagocytosed by the resident macrophage. If this situation persists, the lung will become sclerotic. It will become fibrous. However, I do not think that this is the case here, because I can see the hemosiderin pigment deposition in the macrophage. However, I'm not sure that I see sclerosis. This is still an acute condition. But let's have a look at the other slide, this one. Now, this one, I can see some areas. Let me find the hemosiderin deposition again. It's most probably here. However, since it might be the one you saw in the macroscopic specimen, it could be carbon. You have to perform the stain. You perform pearl stain, and you identify this brown appearing pigment as hemosiderin, okay? So in these areas that we have hemosiderin deposition due to congestion in the pulmonary circulation, this is carbon. You see? It's different. It's black, Theophanis. Whereas the other one we saw was brown appearing. However, pearl will discriminate the two. And when some sort of tissue, some sort of thickening of the intraalveolar septa by fibrous tissue, this might lead to sclerosis due to circulatory dysfunction. Okay? Another type that may lead to sclerosis. And also another lesion that in the long term may lead to fibrosis is this one. The diffuse alveolar damage. Have a look at the slide. This slide, please open it in your electronic devices. Yes. What do we see here? We have the lung parenchyma. Please identify these structures that you see here. Which structure are there in the middle? And what do they have on their wall? Because they are large enough, so they contain this. Excellent. Yes, Theophanis, that's right. What is this tissue around the wall of these structures? Can you? Cartilage. So what structures are these? Excellent. Large bronchi. They are not affected by the lesion we are studying. They are normal because the adjacent alveoli here, you see that some of them are distended, and instead of pneumonocytes, they have this amorphous, bright pink material known as hyaline membranes. Hyaline membranes. So this is the histological hallmark of diffuse alveolar damage, clinically known as acute respiratory distress syndrome. Here it is in a premature newborn, so there is not enough surfactant production due to the immaturity, so that the lung expands. And what is the consequence of this? The alveoli collapse to each other, and we have either atelectasia of the lung parenchyma. However, in some damaged alveoli, we can see the hyaline membranes, as shown here. But let me look for an atelectatic. Yes. This is atelectasia. You see? There is not enough space. There is not enough air space in the alveoli, and this is atelectatic. In this case, due to absence of surfactant production. So, this is the case of an ARDS in the newborn. However, there is a large variety of causes in the respective lesion in the adult. Sepsemia may turn to ARDS. Severe trauma may also lead. Suffocation in water can also, drowning, can cause this thing to the alveoli. But if the patient manages to survive, the whole organization of the destructive tissue will lead to fibrosis. So this is another case that might lead to restrictive lung disease due to fibrosis. So if you see fibrosis in the lung, you may think of all these causes, organization of and complication of pneumonia, complication of left heart failure and congestion in the pulmonary microcirculation with hemosiderin deposition in macrophage and fibrosis. ARDS, which on the long term causes fibrosis, or is it idiopathic fibrosis? This has to do with idiopathic lung fibrosis, most commonly related to common interstitial pneumonia and other rarer causes which are important to identify in the biopsy of the lung, because you have to know on the long term when will transplantation will be necessary for the patient, because each type of this sort of idiopathic fibrotic lung disease has a different clinical course. So it's a particular field of interest if we have an interstitial pattern of fibrosis not related to the cases that we saw together, if to make the correct identification. And I think you had a particular course on idiopathic fibrotic diseases of the lung. Isn't it so? I thought it wasn't. It wasn't this year, it wasn't done this year, and so if it wasn't done, anything you see from my slides then. Yeah, please?
Is the acute phase of ARDS in children and in general in adults if you have the case of...
You have the hyaline membranes.
Yeah, but I'm not sure, but I remember that someone told us we have an exudative phase, right?
It is some sort of exudate, but there are
That's
no
the
inflammatory
danger.
cells. Mainly is destruction of the walls. It is not characterized by a transudate or an exudate. A transudate is common in pulmonary edema. An exudate is common in pneumonia.
So basically that fluid is the surfactant that is lost.
In the case of the newborn, yes. But in the case of the adults, there are tissue remnants appearing in like hyaline membranes instead of pneumonocytes, because this is damage and you cannot have the gas exchange because pneumonocytes are no longer functioning. They are displaced by the hyaline membranes. So these are the slides of non-neoplastic pathology, and we'll finish our lab with the classical lung cancer cases now. So let's start with the squamous cell carcinoma first. This is the slide. Have a look at the slide, squamous cell carcinoma, so that you open it. Now, as previously mentioned, squamous cell carcinoma has a central location. This is evident here because what is this structure? Have a look at the epithelium lining it with all these cilia. Look at the cilia. And the zootostratified epithelium, this is bronchus, a bronchus, okay? This is a bronchus. Yes, but we must have a look if there is some sort of metaplasia of the columnar epithelium and dysplasia. Let me have a look. Because in other parts, you see these foreign structures. You see these islands of tissue, dark staining tissue, because we have the, and you see in the middle of some formations from these atypical cells. You see? What can this be? And we have previously mentioned it in the causes of cavitation in the lung. This is necrosis, but it is necrosis within the cancerous formation.
Insufficiency of blood.
Then?
Due to insufficiency of neovascularization.
Yes, yes, because neovascularization is not enough to supply blood to the cancerous cells. They are biologically aggressive and they need much blood, so they can become necrotic. And from a microscopic point of view, these have to be discriminated because when we have necrosis, we see a formation that it has some sort of a lumen. However, this is not a true lumen. It is due to necrosis. And how can you tell? Because if you see a lumen, you might be confused and think that this is an adenocarcinoma, which is not the case here. So always, when you see lumen-like structures in cancerous formation, you have to identify them as true lumens indicative of adenocarcinomas or false lumen, which you cannot tell, is it an adenocarcinoma, is it a squamous cell carcinoma? So in this case, you see dirty necrosis. Why do I call it dirty? I call it dirty because there are some inflammatory cells in the necrotic material. Let me find again the necrotic area, Theophanis, because you see, here, look. This is dirty necrosis. Why do we call it dirty? Because we have neutrophils within the necrotic material. You see the neutrophils here? Yes. So it is not indicative of adenocarcinoma differentiation. So we need something, in addition to morphology, to find which tumor cancer type is this. So if it is a squamous cell carcinoma, we have to look for keratin production by malignant cells, and we have to look between them for some intercellular bridges which are very helpful in distinguishing squamous cell carcinoma of high grade. Because if it is of low grade, well differentiated, you'll see keratin. However, in lung squamous cell carcinoma, keratin production is not so common. It's not so common. Let us have a look here. Do we see keratin any place? You see here that we do not see keratin, but we see a sufficient amount of pink cytoplasm. This is carbon, this one. It's irrelevant to cancer. You see that it has pink cytoplasm. And this is also a sign, an indication of squamous cell differentiation, because mature squamous cells have pink cytoplasm. But you have to look for bridges between the malignant cells. Of course, they are malignant, so there are many. Did you ask me about mitosis before? These are mitosis. See? This is the mitosis. It's like a line, irregular. So let's look for bridges. You look on the slides yourselves, find the malignant cells, and look for bridges between one malignant cell to the other. Here, you see this one? It's possible. This is a bridge. If we find a better one, yes, it would be better. But it's not always the case, because this is what happens in everyday practice. This is karyolysis. You see all these remnants of the nucleus? So you are not sure. You are not sure that this is squamous cell carcinoma. Keratinization is not so much evident. There are no keratin pearls. So in any case, it's not a well-differentiated squamous cell carcinoma. In some areas, you see some bridges, but not everywhere. What method is there to confirm the type of the tumor? What method? Apart from hematoxylin, eosin, what will you? Yes, please. Yes. Yes, you have P40, which is a nuclear marker. It stains the nuclei of squamous carcinoma cells. You perform the stain. All these cells are P40 positive. So you understand that this is squamous cell carcinoma. However, the differentiation is not so good, because it had those solid structures without evident keratinization. So it appears to be of high grade. Yes, please. Yes, but since it is pancytokeratin, it would be expressed in all other types of epithelial malignant tumors. Pancytokeratin would be expressed in adenocarcinomas, somehow in small cell carcinomas, so it won't be of differential diagnostic value. That's why you have specific immunomarkers for each type of cancer. And as far as squamous cell carcinoma is concerned, we have P40. P40. So, did you find the malignant cells in your slide? Why didn't you open the slides and you always take notes? Why do you always take notes and don't study the slides? Do anything you like. No problem. Yes, please. Want to ask me something?
Yeah, you said it was high grade, and that's because it looks different from the normal.
Yes, it's normal from squamous epithelium, and the only evidence of some sort of keratinization was the sufficient amount of pink cytoplasm in some malignant cells. Okay, if you have experience in diagnosis, you'll think that it is a squamous cell carcinoma. But you have to prove it, confirm it by immunohistochemical positivity for P40. Okay? Now, let's study the other type, which is an adenocarcinoma. Here it is, this one, the first slide in the row. Now, look here. There is an infiltrating tumor. We'll see atypia. However, here there is evidence of differentiation. These are malignant appearing structures having atypia as regard the nuclei of the cells. They have invasion because these structures are foreign to the normal lung parenchyma, and they are dispersed throughout the lung parenchyma. So there is evidence of invasion, there is evidence of atypia, so we have possibly a malignant neoplasm. What do we do next? We look for differentiation to name, to identify the malignancy. And what sign, what histologic sign of differentiation is evident in this field? What sign is evident in this field? What structures do the malignant cells form? What structures are these here? How would you identify these structures? What do they form? You see they are empty here in the center, and the malignant cells are all around. What structures are these? Which tissue do they resemble that forms this? Yes, glands. So there is glandular differentiation. So it comes from glandular epithelium. Since the malignancy comes from epithelium, derives from epithelium, is a carcinoma, and since it comes from glandular epithelium, it is an adenocarcinoma. Now, in this area, the malignant glands are easily, more or less, separated with each other. This is a separate one. This not so much. You see, these two here are some sort of combined. But I want to find an area where the malignant glands of cancer, the cancerous glands, are easily separated from each other. Let's try and find an area, because this has to do with the grade of the tumor. Yes. This is the area. Try to find this in your virtual slide. Who has opened the slide? Don't take only photos and notes. No, you have to study the slide yourself. I have it in the video, and so you can watch the video. Of course, you have to hear my voice all this time. I know this is an ordeal. Yes, I know. But now it's time that you open the slide and find it. Who has opened the slide? You take notes as well. Okay. Yeah, open the slides, please. It's the first slide in the row of respiratory. It's in the documents. The last. You open it? The first one. Okay. Have a nice device here. Yes. If it is high definition, it has some square, and you can play. What's this game? You play in the square. Because you do not. Yes. There are some devices that when you go on high magnifications, some squares appear. That's right. You can play the game. What's the game there you play in the squares? Look, look. What is that?
Chess.
Not chess, the other one that has that and do that.
Checkers.
Tic-tac.
What's that?
Checkers.
Checkers. I don't know. Yes, if you say so, yeah. You play checkers if you do not want to study medicine. It's okay?
I'd rather study medicine.
I know, I know, I know. So, what grade is it here? You see separate glands. So, it's low grade. That means it's well differentiated. The cancerous glands are separate from each other. Not always. Not always in the tumor. There are some other areas where they form some structures, like this one. Look here. One gland. A second one, a third, a fourth. This is more complex. More complex formation, because this is cribriform, a cribriform structure. This is indicative of intermediate, medium differentiation, grade 2 of the adenocarcinoma, cribriform structures. Like this one here. Another one here. You see this one? It's a cribriform. Cribriform. And in other areas, there are solid structures. That means there are no true lumina, because if you look carefully in these solid structures, you might see necrotic material in the center, like this, which is not indicative of glandular differentiation. It's like the one we saw in the squamous cell carcinoma, which also formed solid structures. So if the tumor consisted only of solid structures, you wouldn't tell. You couldn't tell what it is. You would do P40. If it was positive in the malignant cells nuclei, it would be squamous cell carcinoma. And there is another marker specific for adenocarcinoma of the lung, which is napsin A. Napsin A. So you perform napsin A, and it's positive. That confirms the adenocarcinoma, at least in this poorly differentiated component of the tumor. However, it would be useful to perform napsin A, which would identify the tumor as a primary lung adenocarcinoma, and in the other components of the tumor. Why? Because the lung is a very common site of metastasis. So if you have a history that the patient had an operation 2 years ago for colon cancer, or for endometrial cancer, both cancers of these organs are adenocarcinomas. This could be a metastatic adenocarcinoma in the lung. So you need the history, the patient's history, and you also need a marker which is related to primary development of cancer. And such a marker with somehow questionable specificity, of course, because it can be expressed in other tumors, is napsin A. So if the patient's history is free of cancer and you have napsin A immunoreactivity in the malignant cells, either the glandular structures and the cribriform structures and the solid structures, because all these grades are part of the same tumor, you can identify it as primary adenocarcinoma and stage it accordingly. Because if it is metastatic, there is no point in staging. It's the final stage of the previous cancer that has come to the lung. But if it is primary adenocarcinoma, you have to do the pathological staging of the tumor. Okay? And what else can you see in this slide? We have this pattern. Here are malignant adenocarcinoma cells lining some spaces, empty spaces. Do you think that these spaces are glands? Do they look like the glandular component that we previously saw in the well-differentiated component of the tumor? What do the empty spaces look like? They look like alveoli. So this is the lipidic pattern of growth. That means these are walls of the alveoli lined by malignant adenocarcinomatous cells. This was previously called the bronchoalveolar type of cancer. And as you can understand, if this component, the lipidic growth, as we call it now, affected large areas of the tumor, even though there was no invasion, because in this case, there is no evidence of invasion, you just have the lining of the alveoli being replaced instead of new monocytes by carcinomatous cells. What would the patient die of? He would die of asphyxia, because all these parts of the lung could not function and have gas exchange, so he would not die of metastasis or some other sort, but of asphyxia. So this is another pattern that an adenocarcinoma may follow, the lipidic pattern, which, when confined to the lining epithelium of the alveoli, is called in situ adenocarcinoma. But commonly, this pattern is connected with invasion. So like here, you have the lipidic pattern, but in other sites, you have clearly invasive glandular structures. Yeah?
All the cancers we talked about are epithelial origin.
All cancers are of epithelial origin. All cancers are of epithelial origin. And when you have the lipidic pattern, this is an indirect sign that it is primary. Very rarely do other adenocarcinomas involving the gland, such as breast ductal carcinoma, follow this pattern. If you have this pattern, it is another sign of primary development of the tumor.
So it's not going to stay like that for a long time?
It can stay. Paradoxically, yes. But in this case, you'll have the X-ray, and you won't see a tumor. You will see these diffuse infiltrates. Why? Because you have the lining of the alveoli being replaced by abnormal cells. However, sometime it becomes invasive, and it spreads to the stroma. And this is clearly invasion. However, even if it does not invade, it is dangerous because it replaces a potentially large portions of the lung parenchyma. So it is not functional. It cannot function properly. Yes, please.
So you said that when it's confined to the lining.
To the lining
in
epithelium.
situ.
You see here, the stroma. You see the stroma? No glands here. This is one, but it can be an imagination.
Right.
You are not sure that this is invasion.
And that's in situ.
Yes, this one might be an invagination of the surface malignant cells. It's not clear invasion.
But it's called in situ.
In situ adenocarcinoma. What does in situ called? What is in situ called? Non-invasive. Non-invasive. It's called in situ adenocarcinoma. All right? And another what else can we see? This area. Please identify what happened here to the cancerous tissue, and it looks like that. What area is this? We have all these acute inflammatory exudate there, and adjacent to this accumulation of acute inflammatory cells, you have this tissue. What is this area within the parenchyma of the tumor? What is this area where you see no structure and you see just inflammatory necrosis? This is a necrotic area. And you have the acute inflammatory infiltrate, which is not to be confused with the immune response to the malignant cells. This is something different. This is an acute phenomenon that caused the accumulation of neutrophils. However, it is common in cancers. You see here, neutrophils predominate. So this is not immune response against the tumor. We look for immune response if there is any. Here it is. Yes, we have the lymphocytic component. When you see lymphocytic aggregates, this is immune response of the host against the cancerous cells. That was not the case in the necrotic area we saw previously. Yes. When you have an increased immune response, that's good for the patients, so it's good. You should be happy that he has an immune response and always be optimistic. Okay. And the last slide, yes, we have plenty of time, because we have the lab exercise from 10:30 to 12:30. You had the break. The break was when you saw the surgical specimen. We did the break, so we have plenty of time, and we'll finish about 12:30. But as I say, we may finish about a quarter to 12. A quarter past 12. We may finish. We'll see how it goes. We'll see how it goes now with the small cell cancer, which is not so difficult to study because all malignant cells have a common determining feature. Let's have a look at the small cell cancer, which I want you all to open in your virtual slides. Here it is. this one. This is the one, the small cell. You look at it, which slide it is? Okay. Now, have a look in this area. What is this that the cancerous cells have caused? And look at the cancerous cells themselves. They are devoid of a very important site of malignancy. Despite that they do not have this site of malignancy, they are highly malignant and they give metastasis. That's why when such a tumor is diagnosed, you do not perform surgery. You start chemotherapy. So we look at this morphological common feature of malignant cells. The other here on the right is the somehow desmoplastic or fibrous stroma of the tumor, that the malignant cells have altered their stroma and make it some sort scirrhous, that means fibrous stroma. But look at the malignant cells themselves. Let's have a look here. What do they have? They look like each other. They are not atypical with nuclear pleomorphism. They look like each other. And when cells in a neoplasm are homogeneous in their morphological appearance, they might be of neuroendocrine differentiation. So this tumor, being of neuroendocrine differentiation, is expected to express immunohistochemically synaptophysin, chromogranin, ISNM1, neuroendocrine immunomarkers. Ki67 is not a marker of neuroendocrine differentiation, but it will be very high in this tumor, and this explains its chemosensitivity, because tumors which have a very high proliferative fracture are manageable by chemotherapy. And what else is related to this increased Ki67 index? Look, what is this? And this here. Look, how has the nucleus been transformed? What is this here? See? It is hyperchromatic, but also it's mitosis. So it will have increased mitotic activity, and this is another mitosis. You see here how irregular the contour of the mitotic cells are. However, I want you to identify this feature of the malignant cells of small cell carcinoma. This feature here, this one here, this here, this, which is also related, potentially related to this tumor's chemosensitivity. What is this feature? This one that Theophanis shows, this small fragment of nucleus. What can this be? And which is the relative biological procedure which can be targeted by chemotherapeutic drugs that induce this mechanism that is already apparent in the malignant cells and makes them fragmented like this. Which is this? It's the apoptosis. Excellent. Because if a tumor has a high apoptotic potential, as shown by the multiple apoptotic bodies of small cell carcinoma, you can give drugs that further induce apoptosis and destroy the vast majority of neoplastic cells. So, the increased cellular proliferation rate and the increased apoptotic rate, apoptotic index of small cell carcinoma malignant cells are related to their chemosensitivity. So you give chemotherapy and the tumor responds first, but at some time it is no longer responsive to the chemotherapeutic drug, and that's unfortunately the cause of death of the patients. Okay? Is there anything you want to ask me? Oh, we had one. I said a quarter past, and it's 16. It's 12:16. We had 1 minute more of the lesson. Oh, no, no. Not him again. Not him. Please, don't let him come here. Please. Okay, thank you. Bye. Yeah, just a moment.
Why is it called small cell cancer?
Oh, the size of the cells. Yes, it's small. Yes, the size, and there is also a large cell neuroendocrine, which are of different morphology. Just a moment. Let me. Just a moment, please.